Welcome to another episode of The Sex Doctors. Hi, I'm Dr. Abraham Morgentaler.
And I'm Dr. Marianne Brandon.
Yes, you are.
Yes.
And we are The Sex Doctors. So I wanted to talk to you today about an article that caught my eye. It was actually in NBC News Now.
Yeah.
And the title was, More Women Seek Testosterone Therapy, Prompted by Influencers,
Yay.
Doctors Say.
Yeah.
So the A is for the influencers or for testosterone in women?
Well, for testosterone in women.
Yeah. So
Nothing against the influencers. I just
No.
was responding to.
yeah, so you know where this comes from is this observation that more women are coming into doctors' offices, especially OBGYNs, and asking to get their testosterone measured or for prescriptions of testosterone. Oh, hello, and we're joined by Ace Ventura, our pet detective cat.
Yeah.
So nice of you to drop it.
Yeah.
And there you go, showing everybody how you're a little bit itchy.
Yeah.
Yeah. Oh, well, he's clean. He does
Kissed him. He's got pink lipstick on his head, but, it goes well with his whole personality.
So where some of this comes from is that over the last couple of years, there's been an incredible rise in testosterone prescriptions for women in the UK that appear to have been triggered by this idea being promoted by a television newscaster or TV personality named Davina McCall.
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
Welcome to The Sex Doctors, featuring Dr. Marianne Brandon, clinical psychologist and diplomate in sex therapy, and Dr. Abraham Morgentaler, renowned urologist and expert in sexual medicine and testosterone therapy. Together, they bring you expert insights into sex, intimacy, and relationships. Let's dive in.
Okay. It's called the Deina Effect. And what she was promoting was the idea of testosterone in women in addition to standard HRT, hormone replacement therapy, right? Which doesn't normally include testosterone. And the title of this, what caught my eye is the title of this thing basically says that the interest in testosterone is prompted by influencers. And doctors are saying it. That's part of the title. And you can already get the sense that the doctors don't like this.
I see.
Right? Like you're getting information from bad sources. We are the authorities. And what the reason it stood out for me is even though when I'm an academic, mainstream medical researcher, clinician, physicians have gotten it completely wrong around testosterone in men, and I think also in women. And the message has been so negative that this is another version of that negativity, right? You may be hearing testosterone is good from people who aren't like us without our credentials. Don't buy it, right?
Yeah.
I don't mean don't buy testosterone, but don't buy the idea.
Yeah, right.
Yeah, and it makes me crazy.
I'm sure. Like, what's with this negativity?
Yeah. So the problem is, here's between you and me.
Yeah. And Ace.
And Ace. We know that the data on testosterone in women and in men and the clinical experiences of many of these people who have taken it have been superb.
Yeah.
Right?
Right.
And the safety, excellent.
Yeah. So
where's this negativity come from? And part of it, I think, is doctors being doctors. Like they're just, it's sort of a badge of honor to be skeptical. Right? Like, I don't know.
Yeah.
But the doctors that do know are by and large, who've done the research, are familiar with the research, are by and large very supportive.
Yeah.
Except that doctors tend to we're also always worried about not looking like we're too gung-ho about something. And so the right position as a doctor is always to say, we need more information.
Yeah.
Let's just use this for
Therapists do that too.
Yeah, let's just use this for the things that have been shown the most, right? And about everything else,
Yeah.
I don't know.
Yeah. Yeah.
You know, what's funny is I'm a sexual medicine doctor. That's really my home base within medicine. And the sexual medicine groups, we love our hormones. For men, especially testosterone. For women, hormone replacement therapy and testosterone. Like, we've seen it. We've seen our patients respond. So sometimes there are differences between what we see in the office and what we see in studies. And one of the reasons is that study results are always averages, right? So, let's say we see 5 patients in the morning on testosterone or hormone therapy, right? And 3 of them say, "Oh my God, this is like so amazing." It's possible that 2 others may not think it's that great. And if you take it as an average, the average improvement of those 5 patients may not be that great.
Right.
But did it help those 3? Like, for some of them, it's like, this
Life-changing.
is life-changing.
It can be.
Yeah.
Yeah, yeah.
And so that's the problem. There's another problem with studies that is a little subtle, but I want to share it. When people do studies, they need volunteers, right? Some of them might be getting a placebo. They're often paid to show up.
Yeah.
You can't give them a lot of money, but you pay for their fare. And you have a nice person who's interested in all sorts of pieces of their lives. You make small talk, and often the people like coming, to wherever the study site is.
Right.
They're not necessarily patients. There's a difference between study subjects and patients. In Boston, where I practiced most of my career, it was expensive to park often. You had to fight traffic. You had to, if you had an appointment, right?
Yeah, for
You
sure.
had to take time off from work.
Yeah.
It wasn't easy. And so if you showed up with, in medicine we call it a complaint, with some symptoms, and you wanted treatment for those, you were motivated. Those symptoms were bothersome to you.
Yeah.
Somebody who just is part of an experiment may have a different thing. They may answer the same question. So often they have like qualifying questions. You need to have, let's say, low levels of a hormone like testosterone.
Yeah.
And you have to have certain symptoms that say, yeah, I've got this.
Yeah. Yeah. Yeah.
But you can have 2 people answer the same way on a question, and one of them is bothered and much more than the other.
Right.
Right?
And if you're a study subject, maybe you just want the cash or whatever. Like, it's not that big of a deal.
It's sort of like, I'll answer. I think I'm bothered moderately.
Yeah. Right.
Right?
I so see what you're saying.
Yeah. So they're not always the same.
No.
And if you're not as bothered, it's harder to see benefits too.
For sure.
Yeah. Anyway, I just want to put that out. So we just came back, you and I, from an international conference.
Yes, we did.
Yeah.
Amsterdam.
Yeah, we had a great time. We had tremendous faculty.
Well, it wasn't just an international conference. It was your conference.
Oh,
can I say?
It's on testosterone.
I had the honor of presenting there, which was fabulous and fun.
You were amazing.
Oh, well.
You gave them a whole,
Well, let's not digress.
You were great.
Thank you.
Yeah. But one of our colleagues from the UK told us at dinner, as you will recall, that prescriptions for women for testosterone in the UK now exceed prescriptions for men.
Yeah, that's so. I mean, I was like, yay.
Yeah.
I mean, just for the women part, but.
And the weird thing is that in the entire world, there's only one country that has any testosterone product approved for women, and that's in Australia, as it turns out. But in the United States, no. In Europe, no. And so if women are getting this in a fashion we call off-label, like it's not one of the indications.
Yeah.
And women on average take about 1/10. They have about 1/10 the testosterone as men, and they take about 1/10. Yeah.
This whole off-label thing, that's another podcast for us.
That's another podcast.
That's just not fair to women that they're trying to figure out how to manage this with a male dosage.
Absolutely. Yeah. Yeah. I was at another conference, sexual medicine meeting, and one of the great figures in the field, I won't use his name only because I don't have his permission necessarily to say this, but, he was saying, screw the FDA.
think I
And
know
you're
what to say.
talking about testosterone
Yeah.
prescriptions. Well, I say,
Yeah.
well, why do you hold the FDA responsible? I say, isn't it, you need a company to come to the FDA to try and get a product
Right.
approved. And maybe a company doesn't think it's worth it to them financially. He says, no, it's come before the FDA a few times. And the FDA has rejected at least twice products have come to the FDA for approval in women, testosterone products. And
Wow.
and the FDA also has a way to encourage drug manufacturers to come up with products.
Mhm.
For example, if there's a condition that they would like to see more drug development in,
Mhm.
where they think there's a need. Anyway, so
Wow.
that's part of it. So, part of what I was doing in anticipation of today is I was reading some of the articles about some of them are like from key figures. There's one, Susan Davis from Australia, that everybody regards as sort of the key figure in the field of testosterone in women. And, she's responsible for a lot of good. And I think it's probably no coincidence that the one place in the world that testosterone is approved in women is in Australia.
Uh-huh.
But, here's an article by her where I don't know where this appeared in, but it's entitled, Don't Believe the Hype. Menopausal women don't all need to check or increase their testosterone levels. And this is written by her. She's the chair of women's health at Monash University. She's done a ton of research.
Yeah, I've heard her speak several times.
Yeah, and everybody sort of bows to her, and she's like
Oh, people love her.
And, she does what doctors tend to do, which is to say, don't believe everything you hear.
Mhm.
But what happens is that we in medicine, we often set up as these straw dogs, things we can easily knock down, the overenthusiasm,
Mhm.
right?
Mhm.
So
Mhm.
none of these drugs are going to solve every problem in the world, right? And so if you build it up enough, it's easy to knock it down.
Mhm.
The danger, though, in my opinion, is it's too easy to do that.
Yeah.
And what's lost is the nuance, which is this is going to be really helpful for some people.
For some people. Right.
Maybe not helpful for others, but we don't know who.
Right.
And so there's been a thing around testosterone where people say, oh, once you're on it, like you're going to have to stay on that. That's not true.
Oh, I hear that all the time,
Yeah.
actually.
For me, the way I think of it is it's what we call an empirical trial. You're going to try it and see what happens if it's indicated. And it's for 3 to 6 months.
Yeah.
By the 6 months, if a person hasn't noticed anything and their levels are reasonable, it's probably not going to do anything for you. You can stop. What's the big deal? People have made far, far too much out of this. I want to share something, which is that
You're irritating my cat, because if you see his tail twitching just a little, like that means
he's
like I'm
lying on my paper.
well, I'm here to give English to his tail.
Yeah. Well, we know where your primary
That's not true.
affiliations are.
That's not true.
All right. He's asleep.
No.
If he was really bothered, he'd get up and go.
Huh.
All right. So I was privileged to be part of a multi-author paper that had a lot of reach, that I would read you the title of, because it's underneath A. So let's see if I can slip this out. Which is International Society for the Study of Women's Sexual Health. That's an organization which we call ISWISH by abbreviation.
We love ISWISH.
International Society for the Study of Women's Sexual Health. Clinical Practice Guideline for the use of systemic testosterone for hypoactive sexual desire disorder in women, often abbreviated HSDD. Hypoactive means too little, if you will. So these are women who have low levels, low desire, and they're either after menopause, or what this guideline recommends that you can even use this in women who are in advanced reproductive age.
Okay.
Yeah. And I just wanted to read a couple of the takeaway messages, because I
Great.
think this is maybe useful for people. So, number one, androgens, and testosterone is part of a class of molecules called androgens. That's the general term, are essential hormones for development and maintenance of female sexual anatomy and physiology and modulation of sexual behavior. Okay, that's basic. Testosterone has many physiological actions in women directly, and then it talks about how it might do it. There is no testosterone level that can be used to diagnose low levels of testosterone in women or not.
Okay, that's really important. Let's repeat that. There's no testosterone level that can be used to diagnose low testosterone in men or women.
In women. Oh, this is only about women.
Oh, we're just talking about women.
Yeah.
Okay. So what that means is when you get your levels back from your doctor does your medical practitioner takes your hormone level and then it comes back and the lab's got a range.
Right.
You got to take that range with a grain of salt because there's no set in stone range here.
Right. This is somewhat controversial. Not as controversial as the next one, which is the total testosterone concentration is the best assay, the best blood test. So not everybody on this panel agreed with that, but in the end, people have to come to a consensus. No, I don't think that's true.
Right. And what do you think is true?
So this is similar to men, and it's not that complicated, but people make it complicated. So most of the testosterone that circulates in our bloodstream is attached to two carrier molecules. One of them is called SHBG, or sex hormone binding globulin. And what happens is it binds it so tightly that it can't release if its blood's going by a cell that needs it, that's saying, help, testosterone, I need testosterone.
I need you.
I'm deficient, give me some more of that. It can't let go.
Yeah.
So it's not biologically available. So, and the other one is called albumin, or it's the most common protein in the blood. It's weakly bound, and so some of that can be used. But the most important one is the free testosterone. It's called free because it's unattached to anything.
Yeah.
It's just the hormone.
Available for use.
It's for you.
Yeah.
And when there's a cell that says, I need testosterone, the free testosterone goes zip into there.
So tell me, the folks the physicians that say no, total T is the way to go, what are they thinking?
There's more data. So testosterone has been around a long time. Free testosterone, the appreciation of what it does, less long. And there's always been a suspicion of free testosterone, I think, is unfounded. In men, it's clearly been shown, but it's taken a long time to show that it's the key test. And the reason they're different is that the amount of SHBG, that carrier molecule that binds things so tightly, it varies so much in men from one person to another, and in women, multiple times more. Women can develop male pattern balding. They can start losing hair. That's no fun.
No.
They can get too much hair on the rest of their body. They may see dark hairs, like on their chin and elsewhere. They can get thickening of the voice, and they can get enlargement of the clitoris. So if you're going to do this, you got to be monitored.
Yeah.
Yeah. This isn't something that you want to be treated from by somebody you know who knows somebody.
Yeah.
Right.
Right.
You want to have a doctor, and the blood tests are useful for monitoring somebody. So if you're going to do it, you get a blood test for a total testosterone and hopefully also a free testosterone. As a woman or as a man, and then you follow the levels with treatment. And many of the symptoms or the adverse effects that happen in women when you first notice them, if you stop, can be reversed.
Yeah, great.
Right? But not always. So, with any kind of treatment, there are risks. Of course, there are. But what people used to worry about with testosterone women is increased risk of breast cancer. That appears to not be true. And also heart attacks. And that also looks like it's not true. So that's that. But, the difficult thing for me is especially as a physician, academic mainstream physician, is in most situations in medicine, I would say to somebody who had a question, I'd say, well, check in with your doctor.
Yeah.
Right? They're the authorities. They're the experts. And around hormones, unless it's a highly evolved physician, I think that's often a source of misinformation.
Yeah, right.
And it reflects not only the conservatism of doctors, like, well, I don't know if I would go so far, right? There's this example where that's not true. Like, that's what doctors do. But there's also a negativity about it. And I have a lot of discussions with people about why is it that so many in medicine don't believe the results of large randomized controlled trials showing benefits and safety?
Yeah.
And why are they so hesitant to use it?
So why?
I have two colleagues right now where they clearly have low levels of testosterone, as shown by blood tests, where their primary care doctors don't want to treat them. And they provide no good answers why. They're just not comfortable. And one of them keeps being sent for more and more blood tests. He's worried about this. He's worried about that. Let's make sure the levels are okay. And it's just a hesitation. I think that a lot of it, frankly, is a physician's discomfort around sex and sexuality.
Wow. You know what? That never occurred to me.
I think there's a sense that, unlike you and me, who like talking about this stuff, I think for a lot of physicians, they think sex is it's beneath me to be dealing with this.
You know what that reminds me of? So often in studies where they're looking at some medicine's impact on like a woman's sexual functioning, one of the things they'll monitor is how often she has sex. And so often, let me say more than a few times, I've read studies where the increase in frequency of sex was like once a month. And then the commentary about that was, well, she only had one more
satisfying sexual encounter.
Sexual event, they call them.
Right.
One more event a month. Well, if someone's not having any sex and they have a satisfying sexual event in a month, that's a really big deal.
Absolutely.
And who is this researcher to minimize that? Like if someone's having 14 satisfying sexual events in a month and then they add it to 15, okay, not that big of a difference. But if you're going from 0 to 1, that's a big difference.
Yeah. And in those studies, the number of baseline satisfying sexual events was low.
Yeah. Or they wouldn't be on the medicine in the first place. So
Exactly.
I don't get that minimizing that.
Right. And I think that now that's the sexual event.
Yeah.
But it affects people in little ways, potentially every single day, right?
Yeah.
So, people flirt or get flirted with, and it gives them a little bit of a nice jolt, right?
Right.
It's a little something. It just makes your day more interesting, more positive. Somebody has a thought, maybe it's fleeting, about sexual interest in their partner, that they hadn't experienced that in a while. That's not an event, but boy, that's nice to see that. And what a lot of patients say, a lot of people who take testosterone, male or females, they say, wow, I feel like myself again. Like I haven't felt that way in a long time.
Yeah. Yeah.
And so, in science, how you have to try and measure things, right? So we come up with these questionnaires. We call them instruments, these things, like, because they're getting they're trying to get numbers, quantitative information from something that's a qualitative experience.
Yeah.
And sometimes those instruments are pretty good, and sometimes they're a little crude, right? They don't capture the essence of what it's like to live day by day. So they pick on something. And sometimes they're inadequate to describe the human experience.
Absolutely.
Yeah. So I agree with you. And that's one of the comments in one of the articles that I was reviewing before we did our podcast today about the negative reactions to the increased requests for testosterone in women, right? It's like, well, the data just haven't been that good. And the other thing to understand is that when doctors talk about data, they're talking about data usually from large studies, and the data they're talking about, the results are averages for the entire group.
Yes, I learned this from you.
So, I give the example, and here's the drawback. It doesn't tell you about individual responses. Right? So if you have half a population that does better with a drug or something, and half that didn't, those results for the half that did are going to be muted by the half that didn't. You could even imagine where 10%, this happened with cancer drugs. I remember I was in medical school, and there was a drug that we were taught about it, that just got approved. and it increased survival by 1 month.
Uh-huh.
And me and my classmates were like joking, like, who would want to take a drug for 1 month and you have all the misery of taking the drug? But how I learned about it later was that it gave a small percentage of people for this incurable disease. I don't remember, it may have been pancreatic cancer, another, very difficult to treat disease. It gave some of those people like a year,
Uh-huh.
and others didn't respond.
You're right.
So is that worth it for that small group to have a chance? Whereas without that drug, there was no chance
Yeah.
for anybody.
Yep.
But if you do it as an average of everybody,
You-
it comes out to be a very small number.
Right.
And I like to make I use this when I speak to physicians. I say the average number of children per woman in the United States used to be 2.3.
Mm-hmm.
But there are 350 million people in the United States, and not one person was born in a family with 2.3 kills.
That's a very good point. That's exactly what you're saying is you can't appreciate the impact on specific people when you just average the results of
That's
these
right.
huge studies.
And
So,
for some of these people, it may be dynamite, and
Yeah.
for other people, it may be nothing, and
Yeah.
some people are going to be in between.
yeah.
But you don't really get that full flavor from some of these
So
stuff.
what's your advice to women who are listening to this and they're curious as to whether or not testosterone could be helpful to them?
Yeah.
Um, what should they do next?
Yeah. So I think the classic situation is a woman who is menopausal, perimenopausal, or even maybe in their what we call the late reproductive years.
Mm-hmm.
But the ones who are through menopause, who are on hormone therapy already, standard hormone replacement therapy doesn't include testosterone.
I know that always surprises me too. I'll have a client who's, sort of on her HRT and I'll ask about testosterone and she'll say, "Oh, that was never discussed." I'm like, "What are you
Right.
talking about?"
So standard HRT can be helpful in a lot of ways. But a lot of those women still don't have much in the way of sex drive.
Right.
And they don't have much in the way of sex drive because they don't have testosterone.
Yeah.
So I think that, for a lot of those women, the data are pretty good, that especially if their sex drive is down, is that testosterone can be extremely useful. Yeah. So ask your doctor about it.
And then if the doctor says, "Yeah, that doesn't really help that many people," or "I really haven't seen research to support that,"
Yeah.
what does she do then? Does she let it go? Does she?
So listen, there's some people for whom the lack of a sex drive isn't a big deal.
Mm-hmm.
It's true for women. It's true for some men as well. So if it's not important to you, you can let it go.
Mm-hmm.
But if you're not feeling right,
Mm-hmm.
to me, treatment with testosterone is not a commitment for life.
Yeah.
Right? It's often been described that way.
Yeah.
It's basically a 3 to 6 month trial,
Mm-hmm.
and you see how you do with it.
Mm-hmm.
And if you can always stop.
Right.
Yeah. And if it works for you and you feel better, then you can continue indefinitely.
And so if her doctor isn't excited about giving her a trial, then what?
then I think you need to find a different doctor. You can find them online. A good source, as you already mentioned, is a sexual medicine doctor,
Mm-hmm.
right?
Mm-hmm.
So you can go on the websites for ISHWISH, for
Mhm.
smsna.org. We have a society called the Androgen Society that I'm a part of that focuses on testosterone. We don't have referral lists, but if you want information, you can often find it on some of our publications, or the ISSM one. So the sexual medicine docs are all over this. Another group that is really into this is really some of the anti-aging docs,
Mhm.
age management docs.
Mm-hmm.
They're sensitive to it.
Mm-hmm.
I don't subscribe to all the measures that they do
Yeah.
beyond the hormones, but I think that 95% of the benefit that anti-aging doctors see in their patients comes from hormonal treatments. I think that's the biggest thing that one can do in terms of aging well.
Yeah. Yeah.
Yeah. And certainly helps with the symptoms we're talking about.
So you don't have to leave your doctor. You can just get a consult with one of these other folks and see what they say, right?
I think that's right. You get a consult.
Yeah.
And if you like their approach and you want to start with them, that's fine.
Mm-hmm.
Yeah. The colleagues I mentioned who aren't getting testosterone despite having low levels and symptomatic,
Yeah.
they could do that too. And eventually maybe both will.
Uh-huh.
But, people have, they feel attached to their doctors,
Right.
right? And so sometimes it's hard to feel like you're going behind their back. But listen, this is your health.
Right.
This is your life and your body. And if you're not getting where you need to go, there are other resources.
Right. And, I also hear from people saying, doesn't that give you cancer? Like,
Testosterone?
yeah.
Yeah. So the concern in women was breast cancer.
Right.
That's gone now.
Yeah. Yeah.
The concern in men was prostate cancer.
Yeah.
I think that's been definitively shown to not be right.
Right. So these are old fears that are just lingering and making trouble for people.
Exactly right.
Yeah.
Yeah. I think they just get in the way.
Yeah.
Anyway, that's the story with testosterone in women, influencers, and mainstream medicine's really overly conservative approach to this.
Yes. Well, thank you so much, Dr. Morgan.
Dr. Brandon, it was a pleasure as always. So if you like this content, if you find it useful for you, interesting, give us a thumbs up and subscribe and write us a review if you're really motivated. We'd love that. And we hope to see you back here again for another podcast of The Sex Doctors.
Thank you for listening to The Sex Doctors with Dr. Marianne Brandon and Dr. Abraham Morgentaler. Be sure to subscribe, leave a review, and tune in next time for more expert advice on sexual health and relationships.
I believe in miracles. Where you from? You sexy thing, you.